Right, this is a nice gentle warm-up to the day. Hopefully you're all pretty au fait with most of this stuff, so I'm just going to quickly run through what you should be doing in A&E. A few principles, a few pitfalls, a few common things, a few irritations when you're sitting in the foot and ankle fracture clinic afterwards. And also at the end I'm going to talk a bit about the compartment syndrome of the foot and ankle, which is a bit of a controversial topic. And hopefully my phone won't keep switching itself off all the day. So what we're going to talk about is the identification of fractures, how you look for, and the identification of the more important trauma, what you need to do in A&E, and as I said, the compartment syndrome. Now, again, this is stuff you've been doing since you first graduated medical school. History is really important. How did they injure their ankle? Did they just trip off the step when they were coming out the front door, or did they crash their Audi S4 at 120 miles an hour going around the ring road around Leicester? You know, different injuries will happen in different patterns. So do pay a bit of attention to the history, and also listen to them when they say which bits hurt. One of the most common ways people are sued is when they pick up one injury and don't identify the other. Commonly, nasty displaced fracture one foot, minor metatarsal fracture on the other foot. Anything the patient says hurts, get imaging on. The examination-wise, does everyone know has everyone heard of the Ottawa ankle rules? Everyone familiar with those? So basically what that entails is picking up specific points where fracture is going to be, and it's designed to reduce the imaging level in A&E. And the places they talk about are the distal medial malleolus, 6 centimetres posterior border is quite important on that, because the ligamentous tenderness always is at the front. So posterior border tenderness there, posterior border lateral malleolus, fibular head, navicular prominence, and fifth metatarsal base. That's not to say that you only x-ray them if they're in those positions. If there is significant trauma, significant bruising, you still x-ray them otherwise. There's also the category of weight bearing. They have to have been non-weight bearing both on the scene and in A&E to qualify for the Ottawa rules. But there's a big proviso with it as well, which is if they're not weight bearing if they still have pain a week later, then they deserve an x-ray. So something I think A&E departments tend to fall down on a little bit is if you're not x-raying someone who's had reasonable trauma because of the Ottawa rules, you technically should be seeing them back again a week later. Imaging. X-ray of ankle should be 2 views. X-ray of foot should be 3 views, AP lateral oblique. That way you will pick up the subtle injuries more commonly. Again, nothing too stunning. Special tests, we'll talk a little bit about later when we go through the specific injury patterns, but CT scan will frequently be used for some of the more difficult injuries to either identify or to work out whether or not you're going to operate on them. Usually, except in some cases, not going to be happening in the emergency department, so I'll let people talk about that when they go through their own specific talks. Again, don't get x-rays like that. You won't make any friends. As I'll come on to later, if you see a dislocation, reduce it before you take x-rays. Again, nothing that you guys don't know already. There are common things, this is the irritation in the foot and ankle fracture clinic, that you see in feet that are not fractures. The os naviculare, you can irritate it in trauma, but technically it's not a fracture. That's not a cuboid avulsion fracture. I get that every week from the same nurse practitioner. It doesn't matter how many times we go around and say to her that's not a cuboid avulsion fracture, she still sends them around. And the os trigonum and the os naviculare also usually not fractures. Again, you can irritate them in trauma, but that's a slightly different thing. So, fractures. Well, what is a fracture? Again, this is a twee statement, but as I'll come on to later, it's a really important one to think about in the foot and ankle. A fracture is a soft tissue injury primarily that just happens to be associated with one or more broken bones. And in the foot, there's an awful lot of bones to break. There's 28 in theory, if you don't include the sesamoids and accessory bones. Not all of them are equal. I don't really mind if you broke your little toe, but if you've broken your navicular, I'm going to be worried very quickly. So, you know, just because it's broken doesn't mean it needs to come to fracture clinic straight away. And ideally, a broken toe can just be budgie strapped and sent on to GP or A&E follow-up, as long as it's not the big toe. Might worry about the big toe. There are some very important associations with certain fractures that you do need to worry about. Otherwise, you'll be in front of him. So calcaneal fractures or pilon fractures. doesn't take a lot of common sense to work out that those are high energy injuries, and they're usually an actual blow that does it. And thinking, you sort of realise you need to look elsewhere in the body, and the classic one is axial skeleton. So whenever you see somebody with one of those injuries, you need to document that you have looked at, examined, and if necessary, imaged everywhere else on the axial skeleton that can act as a transference of that force. And that's really important that you've documented that. First and second metatarsal base fractures. Anytime you see any sort of a fracture around the first and second metatarsal base, look for that. Does anyone know why? I beg your pardon? Yeah. Do you know what that sign's called? Dead easy. Plantar ecchymosis sign. Again, this will be come on to, I'm sure, in the Lisfranc talk, but it's, if you see that and you've got a fracture in the base of a foot, or even if you haven't, you've had a significant foot trauma, you've got to worry about a Lisfranc injury. Cuboid fractures you again look for Lisfranc and look for other foot trauma. Very, very, very high incidence of association with other foot trauma, to the extent that some of the textbooks will say always. I don't believe in saying always or never, because I always get caught out when I say that. And medial malleolar fractures. Be cautious of the avulsion type medial malleolar fracture that you see on its own. That one's fairly obvious, and you know you're going to see that when you look further up. But if you see an isolated medial malleolar fracture, you've got to be just very aware that there may be a syndesmotic injury and quite possibly a meson nerve type fracture. So treatment. As I said a minute ago, the foot and ankle and fractures around the foot and ankle and fractures anywhere are a soft tissue injury first and foremost. Everything you are doing in the emergency department is to minimize that soft tissue trauma to allow what needs to be done later to be done without excessive delay or without excessive complication. So, how do we do that? You want to, the top three of those are pretty much what I'm talking about in this area. And they're all done fairly much through the same thing, which is reduce the deformity, temporary stabilization in the emergency department, and swelling control. Elevation and AV foot pumps will come as you go down the line, and I'll mention the AV foot pumps in a second. The reduction of deformity, as we said before with that X-ray, is something you do straight away. And it's a pretty straightforward thing to do. A bit of sedation, a bit of a pull, much better. I have done that without sedation once because I couldn't find any, and actually it worked remarkably well, and the patient said thank you afterwards, which surprised me. If you can't reduce it, got to think why. Ankle fractures usually will reduce quite easily. Sometimes they're very unstable and will go straight back out again, but that's different. But ankle fractures on their own will 9 times out of 10 come back without difficulty. If they're not, you've got to think why. And when it's happened to me before, the most common reason it's happened is because it's not actually an ankle fracture. Clinically, when you look at it, you think that's a subtalar, you think it's an ankle fracture, but it might be a subtalar dislocation or a talar body fracture. And they're harder to reduce. Anytime you can't reduce it, it's important. If you look on this, that is blanched and white. If you sit there and put that up onto the wall just as a routine ankle fracture to be fixed the next day on the trauma list, gets bumped a day, you know, you'll go into theatre at 48 hours and you'll have a patch of dead skin and you're in all sorts of hurt. If you've got an irreducible fracture or an incompletely reduced fracture or dislocation, it's an emergency. It needs to be taken to theatre. It needs to be put back into joint. You do not have a big soft tissue envelope around the foot or ankle to cope with skin tenting and skin ischemia. It will get you into trouble. So the subtalar dislocations, you can still do those in A&E. It's just a matter of thinking about it. And you'll get this on a handout later, so I won't go through this. But essentially, what you're trying to do is what you do with most fractures. You exacerbate the deformity, you pull it, and you push it back round with a bit of counter traction. And it works. You just have to think which way the foot's gone on the talus and work your way through it. It does work. They are harder to reduce than ankles, so you will need good sedation, you will need good analgesia, you'll probably need an anaesthetist there, but it is still possible. I mentioned before the AV foot pumps, sorry. AV foot pumps are not available everywhere. If they have them in your department, I would encourage you to use them. They do work well in casts, they're well tolerated, and they reduce swelling, and they've been shown repeatedly to reduce time from admission to theatre, because they do get the swelling down nicely. And you can fit them, there are brands that you can actually fit in a plaster as you put the plaster on. Trying to get them in Peterborough at the moment. Nottingham have them, Basingstoke have them, some of the other places I've worked at have them, and they do work well. Let's go back forward. Sorry about this. Okay. Is everyone familiar with this document? Does everyone have a copy of this document? Worth getting, worth having available. There was a if you open the door about however many years ago it was that it came out, on the sort of about 8 o'clock in the morning, you'll have heard a collective sigh of relief from all orthopaedic trainees across the country as this document landed on their doorstep, because no longer when an open fracture came through your door did you have to take it to theatre at 2 o'clock in the morning. You know, it allows you to take open fractures to theatre on the next available list as a first case, prepped up and ready to go. But more than that, there's some very, very good points that make. What do you do in A&E? Well, first of all, you don't spend hours washing it out, scrubbing the bare bone end. Any gross contamination, like half a boiler suit, you take out. But you don't spend a lot of time playing with the wound. You photograph it, you cover it, you give them antibiotics, and you give them tetanus. And the antibiotics are quite an important part of it, actually. We recently audited our hospital for this, and despite the fact that in every major bay, in every theatre bay, in every bit of the A&E department, there's the protocol on what they should be giving, they were given a huge different variety of antibiotics. The bad press guidelines are quite clear. 1.2 grams of augmentin or 1.5 grams of cefuroxime given TDS until they're taken to theatre and the wound's covered. At definitive op, they also get gentamicin and vancomycin. The augmentin and the cefuroxime are kept going until definitive soft tissue cover, or 72 hours, whichever's sooner. Okay? And it's clear, and that's what you should be doing. Right, moving on to compartment syndrome. I won't insult you by asking you what the definition of compartment syndrome is. Basically, it's when, I'll tell you, if you get pressure within a closed myofascial compartment sufficient that it closes off the microvascular circulation, cells die. It hurts, it's bad for you. You get cell death and neural damage. It's commonly described, and by that I mean the literature and most of the work and most of the studies that go along with this is all around the upper limb and the tib and fib. It's discussed in the foot and ankle, but most of the information that we know from that is extrapolated from the lower limb work. We don't really know exactly how often it happens. I'll come to that. There's issues with the treatment. We don't really know what happens and what the long-term side effects are from compartment syndrome of the foot. And we don't really know quite how those relate to what the treatment is. So there is a big question mark, is the treatment of compartment syndrome of the foot worse than the disease? And the diagnosis of the foot and ankle trauma is difficult. If you think about it, how do you diagnose compartment syndrome? Well, it's pain beyond proportion for the injury, and it's pain on passive movement. And that's very easy in the tib and fib, because when you move the toes to move the long extensors and long flexors, you're not moving the fracture. If you've got a foot that's been through and been under a rolling machine and all the bones in the foot are broken, it's going to hurt when you wiggle the toes. And how easy is it to say that that's above and beyond what you'd expect from the injury? It's a much harder thing to diagnose, and people talk about compartment pressures, and that is an option which I'll come on to. When you look at the incidences of it, these are some of the papers that I found over the last few days. Crush injuries, there was a paper in JBS America, and that looked at the incidence of compartment syndrome after a crush injury, and it decided 14%. But then you look at how they define compartment syndrome, and they did a retrospective review, and their definition of compartment syndrome was when someone had fasciotomies. Crush injuries with fracture and calcaneal fractures, that's another one. And this one was in current orthopedic related research, or clinical orthopedics related research. Their definition of compartment syndrome was when they saw claw toes on post-op reviews. And so you don't really know that if that's a sort of sequelae of the injury that they had, or whether that's because they had the injury from compartment syndrome. Probably, compartment syndrome happens a lot more than we think it does, and a lot more than we pick up. But exactly how much is a little bit up for grabs. Equally, there's some discussion about how many compartments you really need to think about. I think most people now agree that it's 9 compartments. 5 just in the forefoot, 3 the entire length of the foot, and 1 in the hind foot. And that's what's in the different compartments. And again, you'll get that on the handout. I've talked already about the difficulty on identification of compartment syndrome clinically. It is possible to compartment pressure monitor, but again, it's difficult. If you're going to do it, you're going to do it properly, you need to do all 9 compartments, and you need to repeat it. So it's not easy. So how do you treat it? Well, first and foremost, because you've usually got the patient in a cast, again, you know this, it's not immediately straight to theatre. Try the simple things first. Be thinking about theatre, but try the simple things. Trying to make sure they're normotensive, not massively hypotensive, not massively hypotensive. Make sure they've got acceptable pain relief, but don't rely on opiates to get rid of all their pain. Split and remove the dressings. Now, this is really important. If you've got a full cast on, and this has been shown, and you split the cast down to skin, you get nearly a 70% reduction in the pressure within the compartments just from splitting the cast. If you go all the way down to skin, you get another 10% on top of that. If you then take the cast off, you get another 10%. So you can get up to an 80–90% reduction in the pressures within the compartment just by taking the cast off. Don't forget that. It's well worth doing. And don't put the leg, don't hang them upside down, basically. Get the foot about the level of the heart. If you go too high, you reduce tissue perfusion pressure. If you go too low, you'll get edema. So just about the level of the heart is what most people try and aim for. As I said. When you do have to go to theatre, if you do have to go to theatre, there's lots of different ways described of doing it. People talk about pie crusting. I have to say I mentioned that for completeness, really. I think if you've got compartment syndrome and you've decided to take it to theatre and all you do is stick a lot of holes in the skin of the foot, I think you're flying very close to the wind, and I wouldn't be terribly happy if that was my foot. Gold standard treatment for surgery for compartment syndrome is fasciotomy. Gold standard treatment for fasciotomy in the foot is 3 incisions. 2 on the dorsum and 1 up by the heel. So you get the calcaneal department, medial aspect of the foot by the heel, and you get the foot compartments through the 2 dorsal incisions, where you go in between the metatarsals and release the plantar compartments through that way. Can you do it late? No. Just no. If you've missed it, no. By 6 hours, you've got irreversible muscle damage. If you leave it 12 hours, you've got a 50% infection rate and an amputation rate of 1 in 5. If you've missed it, you've missed it. Deal with sequelae. Some people would say that's significantly easier in dealing with compartment syndrome in the first place. If you do miss a compartment syndrome, that's what happens. But it's not without consequences. You know, you get contraction weakness, claw toes, sensory loss. There's some people that talk about, or it's probably true, and this is one of the more serious complications, is the chronic pain issues that you get after a missed compartment syndrome. But you also get chronic pain after serious foot fractures. And this is what I was talking about earlier. We don't really know exactly what the sequelae of one versus the sequelae of the other is. So obviously, if that's going to happen, we should decompress it, shouldn't we? Every time. Be very cautious, be very aware, do it early, you know, get rid of those. Yeah, but that's what happens when you do it. So it's not clear cut. If you look through the literature, most of the papers come out in favour of compartment syndrome decompression if you pick it up. But equally, most of the papers do acknowledge that the sequelae may be quite easy to deal with if you neglect it, and that there's debate about the issue. But most papers do come down on the side of decompression. If you look at the American Academy of Orthopaedic Surgeons website, they do have a risk management section, how to avoid being sued in the States. And they feel that litigation around foot and ankle compartment syndrome centres on the sequelae of a missed diagnosis, much more so than it does on the sequelae of having done something. And certainly in the talks I've had from barristers in this country, they always say you're going to be sued for not having done something far more than you will have been for doing something. I don't want to preach defensive medicine, but it's a consideration. If you've got a florid, crushed foot, obviously with compartment syndrome, with a big high energy injury, I think you probably are duty bound to decompress it. If it's a little bit more equivocal, I think, and it's not quite such a severe thing, I think that it's more flexible. In general, high pressure inside a closed compartment, it's pretty bad for you. It causes lots of damage. I had to find one funny video to put in somewhere. So, in summary, we all know how to identify fractures. We all know how to identify significant injury. When you see it, when it's deformed, reduce it as quick as possible and stabilize it. Look for associated injuries. Remember the BAPRAS guidelines. And be aware of the possibility of compartment syndrome and think about decompressing it. Any questions?